Hi, very good morning. I am Dr. Janak Patel, MD General Physician. These video lectures are for educative purpose and these are some common conditions which we don't recognize quite frequently in our busy hours. So I am representing one such video lecture, that is postural, or we call orthostatic tachycardia syndrome. Short form we call as a POT. Usually, this particular condition will be recognized very frequently when the person gives you a typical complaint, and secondary to that typical complaint, you can suspect and you can make the diagnosis. So what exactly is the postural orthostatic tachycardia syndrome? It is a chronic day-to-day symptoms of orthostatic intolerance plus excessive heart rate when the person is in an erect posture, upright posture. That's why it is called orthostatic. Normally the heart rate will change by or will increase by less than 30. But if heart rate increases more than 30 from baseline or more than 120 after 10 minutes during tilt test in adult, or there is a change in the heart rate more than 40 in the children from the baseline, and blood pressure is usually not low, then this condition we label that as a postural orthostatic tachycardia syndrome. By and large, in a classical only orthostatic hypotension, secondary to hypotension there is a reflex tachycardia because of compensation, but there is a fall of blood pressure. While here there is usually no fall of blood pressure and there is elevation of heart rate, we call tachycardia, and this is because of alteration in autonomic nervous system. It is also labeled as a dysautonomia or malfunction of autonomic nervous system. So this condition is secondary due to abnormal or malfunction of autonomic nervous system. There is another word called as the orthostatic intolerance, that is provocation of symptoms upon standing that are relieved when person acquires a supine posture. And usually these symptoms are exercise intolerance, fatigue, lightheaded, diminished concentration, tremors, nausea, near syncope. A person can get a little headache and sometimes even he can get syncope. So that is labeled as orthostatic intolerance. While postural tachycardia syndrome or POTS, this PO, this is usually written in a small alphabets. So POTS syndrome or POT is a symptom of orthostatic intolerance accompanied by a heart rate increase in at least 30 beats per minute or the rate that exceeds 120 beats per minute, and that occurs in first 10 minutes of upright posture or head up tilt test in absence of other chronic debilitating disorders. So there are two things which are being there. There should not be any debilitating conditions. Person has to be upright for minimum 10 minutes, either without tilt table test or on a tilt table test, and the rate should increase by 30 beats per minute or should exceed more than 120 beats per minute. So there are some diagnostic criteria which are being added, that sustain increase in the heart rate while standing in a children more than 40, and if the age is more than 20, then more than 30 beats per minute. Symptoms are reproducible whenever he stands, and there is an absence of orthostatic hypotension. So when all these three criteria are fulfilled, meaning there are symptoms on standing and they are reproducible whenever a person stands up, and symptom will become less when he acquires an supine posture. During that standing for minimum 10 minutes, if heart rate increases more than 30 beats per minute or it is more than 120 beats per minute and there is an absence of orthostatic hypotension, it is labeled as postural orthostatic tachycardia syndrome. There are some other criteria which are being added, that this particular is a long standing for more than 6 months and there is a disabling orthostatic symptoms. There is a orthostatic tachycardia. We have already mentioned that 30 beats per minute increase in the heart rate on a tilt table or on standing for minimum 10 minutes. Or if the heart rate is more than 120 minutes on a tilt table test on standing, there is absence of underlying condition like lipidating disorders, dehydration, certain medications which produces tachycardia. And if you do a plasma norepinephrine level in upright posture more than 60 pg per ml and there is an excessive isoproterenol response, these are also included in POTS criteria. POTS can be subdivided into neuropathic variety, hypovolumic variety or hyperadrenergic variety. However, all patients do not fit into one subtypes, and there are some terms which are being used in pathophysiology, that is neuropathic variety, hyperadrenergic variety, hypovolumic variety. These three are commonly being utilized, but there is one more term called as a genetic, and third another term which is being utilized is impaired cerebral autoregulation. So pathophysiological wise 5 groups, but usually we come across these three common groups, that is neuropathic, hypovolumic and hyperadrenergic variety. Basically it is a dysautonomia. Dysautonomia means it is abnormal functioning of the autonomic nervous system, and in this particular dysautonomia there are good examples like postural orthostatic tachycardia syndrome, reflex sympathetic dystrophy, Guillain-Barré syndrome which is having neurocardiogenic syncope, orthostatic intolerance, autoimmune gangliopathy, pure autonomic failure, neurogenic orthostatic hypotension, multiple system atrophy, short form it is called MSA, etc. Now this dysautonomia can also present as excessive activity of autonomic nervous system. It can occur as a primary condition in or associated with degenerative neurological disease like Parkinson disease. So this dysautonomia can be seen in many other conditions, and this dysautonomia is a type of a neuropathy. There is a damage to the nerves, and these particular nerves are carrying information from brain to the spinal cord, and from spinal cord to the heart, bladder, intestine, sweat glands, pupil, blood vessels, etc. And when these are affected, there will be abnormality in these particular structures, and that is an autonomic function. That's why the name given is dysautonomia. So you can see that common symptoms of dysautonomia, there are big list of symptoms like bradycardia, abnormally low heart rate, or there can be abnormally high heart rate like tachycardia, disturbances in balance, dysphagia, temperature dysregulation, palpitation, chest pain, vertigo, shortness of breath, frequent nausea and GI dysmotility disorders. Person can also have a headache almost like migraine or may have a frequent headache. Sometimes they can present even as a syncope, chronic fatigue, frequent dehydration, large swing in the heart rate, also fluctuation in the blood pressure, and can have even a fall of blood pressure we call as a hypotension. Person can present in any one of these. This is a big chunk of symptoms and signs which are common in dysautonomia. But in a POTS, there is sudden increase in the heart rate whenever a person acquires an erect posture or during tilt table test. And all those criteria we have already discussed. So for achieving a diagnosis for dysautonomia, usually we use some laboratory tests, cardiac workup, neurological workup and other tests. But tilt table test is the most important and very easy to diagnose good number of dysautonomia cases. Many doctors have got limited or no knowledge of a complex symptoms in patient with dysautonomia, and that's the reason why those particular patients are not diagnosed. At present, there is no cure but ongoing research of offering a hope for a better understanding and new treatment options in case of dysautonomia. So usually we come across a group, this is an umbrella under which you come across postural orthostatic tachycardia syndrome, multiple system atrophy, orthostatic intolerance, neurocardiogenic syncope, or pure autonomic failure. Any one of these can be there under the heading of dysautonomia. If you look in this dysautonomia, that is autonomic disorders, particularly POTS, you can divide into three groups: reflex syncope, POTS, and autonomic failure. If we take a reflex syncope, it will be NCS, situational syncope like maturation, defecation, and many others. And you can have a carotid sinus hypersensitivity. This is neurocardiogenic syndrome, situational symptoms, situational syncope, and carotid sinus hypersensitivity. These are absolutely different from what we call as a POTS. In POTS, it can be primary, it can be secondary. Primary can be partial dysautonomic or beta hypersensitivity, and secondary can be secondary due to diabetes or can be due to joint hypermotility syndromes like Early-Danlos groups of disorders, or maybe because of other conditions. While pure autonomic failure can be acute because of an acute autonomic neuropathy, or maybe in a chronic where it can be primary, autonomic failure or multi-system atrophy like in Parkinsonisms or cerebellar disorders or a mixed disorders, or can be purely in Parkinsonian or Parkinson disease. Secondary autonomic failure are very frequently in a paraneoplastic disorders, diabetes, etc. So these are the three big groups. It is being divided into reflex syncope, POTS, autonomic failure. We are going to talk only on POTS, which can be primary, can be secondary. And usually secondary is due to diabetic group of people as a complication of diabetic autoneuropathy, or in a person with what we call as a joint hypermobility syndrome, and that is quite common in a person with connective tissue disorders like Ehlers-Danlos. So orthostatic hypotension, you can have an initial orthostatic hypotension or a pure orthostatic hypotension, or you can have a POTS where it can be neuropathic or hyperadrenergic or hypovolumic, or you can have a orthostatic hypotension also in case of vasovagal syncope, and we have already given you this classification before. There are multiple variants like partial dysautonomia can be neuropathic POTS, Central variety can be hyperadrenergic POTS, or you can have a norepinephrine transporter dysfunctions, autoimmune antibody to acetylcholine esterase receptors. These are also one of the classifications. There is another group which is being labeled as a chronic orthostatic intolerance, where it is divided into different groups, that is POTS with high flow, POTS with low flow, neurocardiogenic syncope, and IST. Now, as far as the etiology is concerned, it is because of the distal denervation, hypovolemia, change in venous function, cardiovascular deconditioning, baroreflex abnormality, increased sympathetic activity. In some groups, it is genetic abnormality. It can be post-viral or tick-borne. It is very frequently associated with mitral valve prolapse, chronic fatigue syndrome, mast cell activation abnormality, Ehlers-Danlos, or we call joint hypermobility syndromes, even in case of a Raynaud syndrome. These are associated along with POTS. As far as secondary group is concerned, we commonly see in diabetic and joint hypermobility syndromes. Also, it can be seen in a paraneoplastic groups and others. While in case of a primary variety, usually in a partial dysautonomia, it is post-viral, maybe genetic, or maybe other groups. And another variety is because of a hyperadrenergic variety, or we call neurogenic variety. This is a big list of other causes. You can get also due to chemical exposures, hypermethylation, diabetic, nitric oxide deficiency, thyroid disorders, liver disease, severe anemia, tumors, lupus, angiotensin II, autoimmune disorders, cardiac atrophy, mitochondrial disease, neuropathy, nutritional deficiency, Chiari malformation, Zika syndrome. There is a big list. Addison's disease, multiple sclerosis, adrenal disorders, viral infections, big list. As far as epidemiology is concerned, female are more prone as compared to male. Almost ratio is up to 5:1. There are some trigger factors like flu-like illness or maybe autoimmune disease following surgery or following injury, even pregnancy or rapid growth spurts. It is quite frequently associated with a joint hypermobility syndromes like Ehlers-Danlos. Young woman may be underweight, and you need to differentiate from the other eating disorders. Hot weathers or hot showers worsens the symptoms. This is very peculiar, and cognitive function may be affected in some of the person. There are different pathophysiology which are being proposed and explained. One is hypovolemia, abnormal baroreflex. Normally you get an tachycardia following a severe hypotension. There is increased sympathetic activity. There is a peripheral sympathetic denervation. There is a cardiovascular deconditioning. It may be associated with an autoimmune phenomena. And there is also somatic vigilance. And because of some abnormality in this autonomic center, which is having input from carotid body and giving an order to heart and via autonomic nervous system to peripheral blood vessels, etc. This particular phenomena is being disturbed. So usually a person, when he stands up, you can see that the venous pooling in lower limb increases. So because of this, the venous return to the heart is reduced. Also there is a venous pooling in upper limb also. All that will decrease the central blood volume. So there is decrease in the arterial pulse pressure. So the receptors are stimulated. There will be increased sympathetic outflow, decrease in vagal tone. There will be veno-arteriolar reflexes, and there will be activation of a renin-angiotensin system. So there is a nice balance between parasympathetic activity and sympathetic activity. Here sympathetic activity is more, so there is an increase in the heart rate. There will be increase in the blood pressure. It may be associated with dilatation of pupil, constriction of the peripheral blood vessels, and there is also fight and flight response which will inhibit the digestive process. While if there is a sympathetic system, parasympathetic system which is more active, then it will reduce the heart rate, it will reduce the blood pressure, there will be constriction of pupil, there will be peripheral vasodilatation, person will be relaxed, sleep will be induced, and there will be also stimulation of digestive symptoms. Digestive system will be stimulated. If you go through your clinical features, usually we divide into two big groups, cardiovascular symptoms and non-cardiovascular symptoms. So any person who complains of this group of symptoms in an erect posture, you should keep it in mind. After ruling out the orthostatic hypotension, and if during erect posture you get tachycardia, which is reduced by supine posture, you must suspect POTS. So in a cardiovascular system, mainly the symptoms are palpitation, exercise intolerance, and person may have a pre-syncope or syncope. And because of decreased blood supply to brain, person also complains of light headache to a severe headache. As far as the non-cardiovascular symptoms is concerned, on an erect posture, person will complain of fatigue, anxiety, even tremors. Person might have a severe headache. There is something described as a brain fog. And person can have even a GI symptoms in the form of nausea, vomiting. So by and large, the classical presentation is palpitation, fatigue, light headache, exercise intolerance, nausea, headache, and syncope or near syncope, if these symptoms are on erect posture. So all those symptoms what we have described, dizziness, palpitation, nausea, vomiting, abdominal symptoms, all these symptoms can be abrupt or gradual, can wax or wane, but symptoms can be aggravated by exercise, by a postprandial state, or during menstrual period, or on exposure to heat, particularly after a hot shower. And good number of time you will see hypermobility of a joint. So joint hypermobility syndrome may be associated quite frequently in this particular group. And if you see the percentage of the symptoms, light headache is almost in 95% of the people, dizziness in almost 80%, palpitation in 55%, exercise intolerance in 85%. Indirectly, light headache, dizziness, and exercise intolerance are topmost on the list. And other symptoms, which can be blurred vision, chest discomfort, and dizziness. Also, person can have stomach pains, cramps, vomiting, brain fog, or cognitive confusions, etc. And lower limb may show you purple leg or dark red legs. These are peculiarity which you can see. Good number of time person can have a headache which can be suggestive, almost like migraine. And particularly this will be on standing. If you divide those symptoms because of sympathetic effect, there is a constriction of blood vessels, You have got a cold, clammy extremities and fits because of adrenaline secretions, anxiety, insomnia. Pupil dilatation can be there because of sympathetic overactivity. The person will have a light sensitivity, and secondary to sympathetic activity, person will have a tachycardia, increased blood pressure and light headache. Secondary to cerebral hypoperfusion, light headache, blood vision, cognitive difficulty, generalized weakness. There will be high flow plots and low flow POTS. Excessive sympathetic excitation will produce palpitation, chest pain and tremors. So depending upon this, you will be able to pick up and say high flow and low flow POTS. You can see sometime, particularly in a joint hypermobility, migraine is very common. While POTS alone, usually you don't come across migraine as a common symptoms. And you can see the difference. This is in a supine posture, the limb, and this is in a erect posture, which is showing you a redness, and person is having a hypermobility. This is quite common. So if POTS is there with a hypermobility, they will invariably have quite common. Almost 73% of the people can have a migraine, while POTS alone, only 28% will have a migraine. So limb from normal color becomes purple color or reddish. That is also one of the clinical signs in case of POTS. For diagnosis of POTS, you will have to suspect, you will have to screen, and you might have to undergo investigations. So disease is not difficult to diagnose, but it is misdiagnosed because person description or symptoms are good number of time misdiagnosed as anxiety or depression, and is referred to a psychiatrist. If you suspect a person, any person who is complaining of symptoms only on standing, and during that particular time measure the blood pressure and look for the pulse. If there is no fall of blood pressure and there is increase in tachycardia, it is in favor of POTS. But if there is a fall of blood pressure, then it is in favor of a postural hypotension. And the best way to differentiate those, tilt table test is very important. You can go for some of the blood tests to rule out other associated conditions and look for heart rate upon standing. So this is a simple most test which can be easily done. You don't require a sophisticated investigations, and you can suspect POTS. So this is the best way, tilt table test. You can have a ECG, you can have a blood pressure recording, and you have a pulse examination. And you can have a even monitor. So that can be done. So diagnosis will be there. There will be exaggerated increase in the heart rate with a particular standing posture. It is not 90°. There is an increase in the heart rate greater than 30 beats per minute, or heart rate will be more than 120 within 10 minutes of tilt table test, and there is no orthostatic hypotension. Very, very useful. And this will be helpful to differentiate neurocardiogenic, POTS, dysautonomia, cerebral syncope, and psychogenic syncope. Very, very important. Because in orthostatic hypotension, during erect posture, there will be fall of blood pressure. While in case of a POTS, there is no fall of blood pressure. Systolic blood pressure remains normal. While here, there is a fall of blood pressure and there is a slight elevation of a heart rate. While diastolic blood pressure and systolic blood pressure both will fall. While here, systolic blood pressure will remain nearly same. Very, very important clue. This is in a dysautonomia. You will have a heart rate increase and there will be sharp fall with head down, and then there will be little rise. In a neurocardiogenic, heart rate and blood pressure both will fall. While in case of a POTS, you can see that heart rate increases, blood pressure may have a little fall but not to a hypotensive level. This is characteristic of POTS. Good number of time this remains same, nearly same. These are the different pictures which are showing you in autonomic failure, neurally mediated syncopes, and in case of a POTS. So there is a tachycardia and there is no change in the blood pressure. While in case of a neurally mediated syncope, there is a sharp fall. While in case of autonomic failure, you can see here the heart rate, and heart rate remains same. There is no change, while there is a fall of blood pressure. There are a lot of conditions which mimics identical, like orthostatic hypotension, dehydration, hypothyroidism, inappropriate sinus tachycardia, where even in supine posture person will have a tachycardia, recurrent vasovagal syncope, anxiety disorders, chronic fatigue syndromes, etc. All these are the common conditions which you will have to differentiate, of which the one of the most common is orthostatic hypotension. And again repeating, orthostatic hypotension is easily differentiated because in a erect posture there will be fall of blood pressure, while in case of a POTS there is not much fall of blood pressure and there is an elevation of heart rate. There are other conditions which also you will have to differentiate, like pheochromocytoma, then drugs, etc. As far as management is concerned in POTS, persons should go exercise training, avoidance of deconditioning, volume expansion can be done by increased water intake, and also sometimes it is along with little increase in the sodium intake. Person can use compression stockings, and very frequently mineralocorticoid in the form of a fludrocortisone is being utilized, which will reduce sodium excretion by kidney and will help in increasing in the blood volume. Some of the medications which can be also utilized is alpha-1 agonist, which will produce vasoconstriction. Propranolol, particularly beta blocker in the form of a propranolol, will reduce the heart rate, but it also will give rise to fall of blood pressure. So this is not commonly being utilized. Ivabradine will inhibit the pacemaker, and by which it will reduce the heart rate, and this does not have much effect on a blood pressure, so this is a better molecule than propranolol. Clonidine is alpha-2 agonist, which will also reduce the heart rate, but simultaneously clonidine will also produce, being a centrally acting drugs, will also produce hypotension, so this is usually not recommended. Pyridostigmine, which inhibits the acetylcholinesterase, so this will be useful in a person who has got acetylcholinesterase receptor agon antibodies. In that group it may be of help, where it will be by acting, increasing the parasympathetic activity, it will reduce the heart rate. Of that, ivabradine, fludrocortisone and alpha-1 agonist are better useful, because these two conditions will help in increasing the blood pressure, while ivabradine will help to reduce your heart rate. Volume expansion is usually done by water, liberalization of salt intake. Very rarely they require saline infusions. Particularly if the person is severely anemic, you can give iron replacement. Venous pooling should be limited, and that is done by avoid standing for long period. Compression stockings, and encourage different types of stocking depending upon what you require. We have told you that as far as medication is concerned, beta blockers, which prevents the restriction of the blood vessels. Benzodiazepine can be used to relieve the anxiety. Diet low in gluten and high in sodium is commonly preferred. Exercise and avoiding staying in bed all day long is avoided. So staying in bed should be avoided and little amount of exercise tolerance should be done. And person should remain well hydrated. Usually we face some of the challenges in treating POTS. While starting an exercise regimen, you have to be very careful. Anxiety should be relieved. While going to work and school, you have to train them, and frustration due to other misunderstanding of the disease should be avoided. So there are psychosomatic symptoms also being present. In a neuropathic POTS, there is a defect in loss of regional vasoconstriction. So you can partially overcome by physical counter maneuvers, salt and water loading. You can use a vasoconstrictor, exercise, rapid water ingestion, etc. And in hyperadrenergic variety, you can again have a physical counter maneuvers. You can use beta blocker. You can use angiotensin receptor blocker, or you can use fludrocortisone, which is one variety of a mineralocorticoids. So in general, fludrocortisone, beta blocker, or you can use even a calcium channel blocker. Some person also uses SSRI or NRI. Pyridostigmines, oral contraceptive pills, and there is a big list of all these medicines which are there, out of which fludrocortisone is very useful. In a person with sympathetic overactivity, beta blocker or calcium channel blocker can be useful. To relieve your anxiety, etc., SSRI can be used. Pyridostigmine is useful in very few conditions, particularly who has got a acetylcholinesterase receptor antibodies, etc. Pharmacotherapy is employed to the patient who feels well enough so that they can begin with reconditioning programs, etc. What should be avoided when the person is diagnosed with POTS? Extreme heat, donating blood. He should not get dehydrated. Lifting heavy objects. Coffee should be avoided. Large meals should be avoided. Food high in gluten should be also avoided. Alcohol. Sudden standing. He should get up slowly and stand slowly. Holding arm in air for extended period of time. Energy drinks should be avoided. Anesthesia should be given only under supervision of physician. Stressful work environments, climbing large flights of stairs, suddenly climbing for a large number of flights should be avoided. This is again same big list, whatever is given before. Some of them may be some additional. By and large, the outcome in a patient with a POTS, 80% recovers by mid-20s. Adult onset, large percentage of recover within 2 to 5 years. Very few number of patients will suffer from a long-term disability associated with POTS. So good number of people recover with POTS. But you have to keep a close observation, and you should give diagnosis and followed by a proper treatment. Complications, very rarely person goes into a chronic stage, or we call it a long-term persistence of a POTS. By and large, the person who gets syncope can have a fall and can injure himself. Good number of people get psychosocial problems, quite common. So, in summary, orthostatic intolerance defined by symptoms when the person is upright and it is relieved by lying down. Orthostatic hypotension is a form of orthostatic intolerance. In orthostatic hypotension, there is an orthostatic intolerance, but there will be hypotension in an erect posture. There is another group we call as a postural vasovagal syncope, is most common form of orthostatic intolerance. POTS is usually chronic and there is circulatory system not responding to the autonomic input properly. There is a hyperadrenergic state, and this is very common in a person who are chronically bedridden person, and then they suddenly move about. POTS is a very commonly underdiagnosed syndrome with a multiple clinical manifestation, and good number of times this is referred to a psychiatrist. Lifestyle modification can dramatically improve the symptoms. There are many treatments including volume expansion, SSRI, beta blockers, fluorocortisone, etc. Exercise has got a very good benefit in those patients who can tolerate the exercise program. Recognizing the symptoms will help the patient to improve their quality of life. So early diagnosis, early recognition and early treatment will improve the quality of life. I thank you all for taking out time. I know that your time is valuable and I appreciate you for spending some of the time with me. I hope this will be helpful to you. You may come across some of the patient who specifically complains of good number of symptoms in erect posture and in erect posture for 10 minutes. If there is increase in the heart rate more than 30 or there is a heart rate more than 120 per minute and there is not much amount of fall of blood pressure in an erect posture with multiple symptoms, do suspect POTS and you can have a good recovery. So I end my lecture here. I hope this will be helpful to you. See you in next lecture. This is mainly for educative purpose.